Oh, that's perfect. Well, thank you for the invitation. It's my pleasure to be here. A little disclosure, I was creating this and I realized that I put up to 50 slides. And so there's no way we're going to be able to get through all of this. So I'm going to rely on your chiefs to reschedule me to go over some of the oxygen therapy component. But I've broken it down into mechanisms and then we'll do some oxygen therapy. So I'll rely on them for a rescheduling so we can finish this. And the other thing is, many of you have had exposure to ultrasound now, either through the sim lab or through some of our ultrasound electives. So I want to start incorporating this into some of the lectures, and I want to really show you how you can utilize ultrasound in the management of a patient like this, somebody who's presenting with acute hypoxemic respiratory failure. I will be using Poll Everywhere. So, you know, when I log in, you'll be able to see how to, type in everything. I'm sure you've used this before. So we'll go to these questions as they come up. So let's get started. So some objectives. It's always clear to have expectations up front. What do I want you to get out of this presentation? What do you guys want yourselves to get out of this presentation? And so it's very clear right here. So being able to classify the 4 types of respiratory failure, and I'll show you how to do that. Describe the basic pathophysiology, and I do mean basic. Some of these are quite complex, and there's also overlap between many of the types of respiratory failure and the mechanisms of hypoxemic respiratory failure. So I've broken it down to simplify it, but understand that it can be quite complex. Utilize ultrasound in your approach. That's something that you should be incorporating now into your routine practice. And then be able to describe the various oxygen therapies. Like I said, that's hopeful that we'll be able to get to that, but definitely that's something we'll be able to go over in the future if we don't get to it today. So basic terminology and definitions, always important to start with this. This is a busy slide. Rule number 1 when you're creating a presentation, don't make busy slides full of words, but it's absolutely essential that you understand these concepts whenever we're talking about hypoxemia. So SaO2 is your arterial oxygen saturation. Can you guys see my mouse if I'm pointing at things?
Yeah, we can see it moving.
Perfect. So SaO2 is our arterial oxygen saturation. This is a direct measurement using an ABG, looking at the percentage of hemoglobin saturated with oxygen. This isn't something we commonly report. We normally talk about SpO2, which is your peripheral oxygen saturation. So the percentage of hemoglobin that's saturated with oxygen, and it's measured by co-oximetry using different wavelengths of light. Now, normally your SpO2 and your SaO2 do correlate. However, there are conditions where you might have a discrepancy between the two. People who have methylglobinemia, carboxyhemoglobinemia, it doesn't discern the differences. So you have to understand that when you're utilizing SpO2. PaO2 is the oxygen tension in plasma, so the amount of dissolved oxygen in plasma. This is something you commonly look at when we're calculating a PF ratio. AA gradient, something you need to know. The pulmonary fellows have to know this. It's not something you see as often anymore, but I'll show you how the AA gradient does play a role in your evaluation of a patient with hypoxemic respiratory failure. And it's simple. It's the difference between the alveolar oxygen content and the amount of oxygen dissolved in the plasma. Now, things we have to remember is it's not a fixed value, okay? It changes with age because obviously our VQ, our ventilation to perfusion, and also the integrity of our endothelium on the capillary side and the epithelium on the alveolar side changes with age. It doesn't function as well. So ways that we can calculate this is quick formula, 2.5 plus 0.21 times the age in years. One thing that we teach the pulmonary fellows is a simple way is age divided by 4 plus 4. And so they'll tend to correlate plus minus, 3 to 5. So that's within the area, the range of error. The PF ratio, again, the PaO2 or your arterial oxygen divided by the fractured of inspired oxygen. This is something you typically see in patients who are mechanically ventilated, right? You need to know the FiO2 with some degree of accuracy in order to calculate this. And obviously, if we can talk about ARDS in another lecture if you guys would like, but the PF ratio is certainly important for prognostication. And then part of the Berlin criteria for breaking up ARDS into moderate, mild, moderate, and severe based on PF ratio. Mild being 200 to 300, moderate 100 to 200, and severe less than 100. Now, hypoxemia and hypoxia, these are two critical terms that you have to differentiate. Many people, including fellows, use these interchangeably and think they mean the same thing. They do not. All right, and I just have to clarify that up front. Hypoxemia is a low arterial blood oxygen, so a low PaO2 or a low SaO2 or a low SpO2. Hypoxia is insufficient oxygen supply to tissue. So two different things. And I have here underlined, you can have hypoxemia, which can lead to hypoxia, but it's not the only cause, right? So there's many other causes of hypoxia, such as lack of perfusion, anemia, if somebody had hemorrhagic shock, cardiogenic shock, and also vice versa. You can have hypoxia, so lack of supply of oxygen to a tissue without hypoxemia. And a classic one is cyanide toxicity, where you can't utilize oxygen at the cellular level. So understand the differences between the two. And then finally, a complicated formula that I have down at the bottom, oxygen delivery. This is probably the last thing you need to know to really understand gas exchange and also oxygen delivery to tissues. And your oxygen delivery is basically composed of two things, your cardiac output and your oxygen content. And your cardiac output, we're very familiar with our preload, afterload contractility. You can manipulate these in many ways. Preload, you give fluids, afterload vasopressors, contractility, inotropes, or something with chronotropic activity to increase the heart rate. And then our oxygen content is basically 1.34 times our hemoglobin. So this is why it's important to maintain some degree of hemoglobin. Usually we say above 7 based on the trials, the TRIS and the TRIC trial being the big ones. And then our oxygen saturation. So you can see this plays the predominant role in terms of our oxygen delivery. And then you add 0.003 times the PaO2. So dissolved oxygen plays a very minimal role in terms of oxygen delivery to tissues. Really the big thing is hemoglobin, and then your oxygen saturation, the amount of hemoglobin, oxygen bound to hemoglobin. So that's quick. I just wanted you to understand those concepts because they're important as we take ourselves through hypoxemic respiratory failure. So we classify respiratory failure. There's 4 main classifications. Type 1 is hypoxemic. Usually that's recognized as a PaO2 of less than 80 or an SaO2 of less than 90, but it's really dependent on the patient, right? There's no fixed value for any person. There's 5 main mechanisms. And one thing that I'll show you is there's a lot of overlap. Like I said, I broke this up into 5 mechanisms to simplify, but there's a lot of overlap between the different mechanisms. Type 2 or hypercapnic respiratory failure, the hallmark being elevated carbon dioxide. And so there's a failure of CO2 exchange. This is basically with a decrease in alveolar minute ventilation. And to calculate alveolar minute ventilation, you need to understand the amount of lung that has dead space in it. That's a complex topic beyond the scope of this discussion, but just something to be familiar with. Type 3, perioperative respiratory failure. Type 4, respiratory failure due to shock. Big one being a cardiogenic or a septic shock, where your minute ventilation is so high that you can't keep up with the demands in the body to maintain your oxygen delivery. And of course, there can be overlap. You can have type 4 respiratory failure from shock, and it can be due to a pneumonia, so a type 1, where you have shunting. So you can start to see how there's overlap between the 4. But what we're going to focus on is this right here, type 1. Now, to further understand gas exchange, we have to understand VQ. This is probably a concept that has been introduced to you before, maybe just at a rudimentary level, but ventilation to perfusion is something that's essential in the lungs to maintain gas exchange. Now, we're all familiar with this diagram on the left, the apex of the lung up here, the base of the lung down here. You can see ventilation and perfusion tend to match up based on what we call West zones, zone 1, 2, and 3. Now, when we're dealing with VQ is greatest at the apex, but so an important concept you need to understand is ventilation improves and increases as you go down to the base. And that's because, and this isn't an upright patient, that's because you have gravity and obviously the lung parenchyma is much bigger and you have more recruitable alveoli. So in an upright patient, ventilation is greatest at the base. Perfusion is also greatest at the base because of gravity. But VQ is lower because perfusion far outweighs ventilation down in this area. But that's an important concept. When you have a hypoxemic patient, you certainly want to sit them up because it can improve gas exchange. And then when we take this at the more microscopic, I guess, cellular level, you could say, here's the alveolus. And then we have venous and arterial blood. So venous blood coming over here, low in oxygen, high in carbon dioxide, goes through the capillaries, crosses the endothelium, crosses the alveolar epithelium. CO2 then goes out of the lung, and PaO2, or O2, I should say, diffuses across into the blood. And now we have arterial. And familiarize yourself with this picture because I'll utilize this to help explain some of the more complex topics when we're coming to pulmonary physiology and hypoxemia. If you guys also have any questions, stop me at any time because I want to clarify these concepts as we move forward. So since this is a presentation for interns, I thought we'd have a night on the wards for an intern. You're coming in, we'll say it's night float, and you have a nice little break and you start at 9 p.m. and you get your first admission. Right, so we're going to be taking these as case-based, and I think utilizing cases to help understand these complex concepts can really help. So here's our first admission. An 85-year-old male, hypertension, hyperlipidemia, CAD, coming in from a nursing home, altered mental status, initial vital signs stable, CT head negative, and admitted to medicine service for workup encephalopathy. Certainly you guys get this quite a bit. Right, altered elderly patient from a nursing home. You go down there and you notice the patient to be tachypnic to the 30s, hypoxemic to 86% on Romer, and tachycardic to 120s. You speak to the ED team, they look puzzled. The patient was fine, right? But this isn't their problem now because it's admitted. So if you want to call a screen, you got to call the AC. But certainly before you start calling any screens, you're going to work your patient up. So now that many of you are getting more comfortable with ultrasound, I want to start seeing some of your ultrasound skills integrated into image interpretation. So you whip out the ultrasound and you obtain these views. And I want you to then, I'll switch over to the poll. I want you to tell me what these ultrasound findings show. So these are interior lung fields. So this is the right interior. And you guys can see the video. Jacqueline, I'm looking at you. So a thumbs up if the video is working well.
Yeah, we can see it.
So that's the right anterior. This is the left anterior. So it's activated. I'll give you guys a minute to put in your thoughts.
Do they need like a username or anything for the poll everywhere?
Do they what?
Need a username or anything for the poll everywhere?
So text 37607, text James Salonia 785 to 37607, then you'll be able to put in your answers.
What was the first part? Sorry, text what?
Can you see it up here? It's text James Salonia 785. You want to text it to the number 37607.
Okay, I think I put that information in the chat as well.
Perfect. I thought you guys be able to see it. It's pretty big on my screen.
No, we just need the PowerPoint unless I'm completely missing something.
Can you see? You can't see the word, the other file that I'm bringing up right now.
No, we just see the PowerPoint presentation.
Okay. How's this? Better?
Yes, we see that.
Hopefully you guys remember. All right, so we'll finish up 5 more seconds. Everyone's dropping from bilateral V lines and slowly moving over to C. Good. And C is the correct answer. So we'll just take it back real quick. So on the right side, we have B lines, right? These B lines are these vertical lines extending from the pleura off your screen. They're moving with the pleura if the pleura is moving, and they're dominant over A lines. So these are B lines on the right. This is an A line pattern on the left. A lines are horizontal lines. They're basically artifact, reverberation artifact between the pleura, which is up here, and your probe being reflected in air. So it means there's air on that side. So the correct answer, B lines on the right, A lines on the left. So then you do a little more ultrasound and you see this in the right lateral region. So what are the ultrasound findings obtained in that right lateral view? This is a little more challenging. It requires you to actually type in what you see. So what did you guys see over there?
So I think we're waiting to see the options for that.
Yeah, this is a text. Lung hepatization, good. Consolidation, I like it. Hepatization is getting bigger. Fantastic. Any other things that you guys saw? There were some bronchograms in there. I see bronchograms, excellent, right? When I said perfect. Are they dynamic or static? Let's make this a little bit bigger. So somebody's saying static, somebody's saying dynamic. Good. So, definitely you can have some static and dynamic in the same screen. I would argue that there's more dynamic. You can see these air bronchograms moving right in here. This would be your chest wall. This would be your pleura. Sorry, I'm switching it back. I know I got to keep switching it. Chest wall, pleura, this is your consolidated lung. So definitely you guys are right, consolidated. Hepatization looks like liver. You see those air bronchograms moving in here, right? So this is air and fluid in bronchi, which have consolidated lung around it. So you have these B lines on the right and this consolidation and air bronchograms on the right. So what is the most likely etiology to this patient's hypoxemia? Good, absolutely. So pneumonia, the most likely etiology. So hopefully you can see how ultrasound really plays a role in evaluating these patients when they're coming in with hypoxemia. So let me just bring it back again. So finally get your chest x-ray. Sometimes that's delayed. And then you start to see this right down here, this confluent opacity. Remember when you're reading a chest x-ray, you don't jump to a diagnosis and say pneumonia, consolidation, fluid, you describe it. So you have a confluent opacity in the right lower lobe, and now you need to clinically integrate that with other findings that you have. And in this case, you see that dense consolidation with air bronchograms on the right. So pneumonia is the diagnosis. So what's the cause of hypoxemia? So this is something we call shunt. And we talked about ventilation to perfusion. So we're having some VQ mismatch here. So basically, you're perfusing an area of the lung, but you're not ventilating it because you have fluid, or you have edema, or you have pus and white blood cells and bacteria within the alveoli. So you have wasted perfusion. So the blood is bypassing, the lung without being adequately oxygenated. So there's a few forms of shunt, and this is where it can be a little complex. We have a physiological shunt and we have an anatomic shunt. Physiologic shunt is being the one we just saw, pneumonia. So I have blood, venous blood going towards the alveoli. There's no gas exchange, and so it's bypassing those lung units. I can also have an anatomic shunt, and it comes in two different flavors, an intracardiac and an intrapulmonary. So if I'm bypassing going through the heart from the right to the left side without going to the lungs, such as the case in a PFO, maybe an ASD or VSD, when you have increased right-sided pressures, you're going to lead to shunting and hypoxemia. We can also have an intrapulmonary shunt, which can be due to pulmonary arteriovenous malformations, hepatopulmonary syndrome, and somebody who has cirrhosis. And the same thing, you bypass the lungs and you're not engaging in adequate gas exchange. You're creating this right to left shunt. I pose this question here to you guys. What can we perform to differentiate between intracardiac and intrapulmonary shunts? Obviously, if you're familiar with this, you can do a bubble study, right? So you do agitated saline study. You can certainly do this at the bedside. Any one of you can do it if you know how to approach it. And basically, you're just looking for bubbles, which will appear first on the right side of the heart. And normally, you won't see them on the left side because all the bubbles are absorbed into the lung parenchyma and the capillaries. They don't pass by. If you have an intracardiac shunt, you'll see the agitated saline. Those bubbles pass from the right to the left heart within 3 cardiac cycles. If you have an intrapulmonary shunt, within 5 to 6 cardiac cycles, you'll start to see agitated saline go from the right to the left side of the heart. So definitely a bubble study, agitated saline study, something we do quite frequently in the ICU if we feel that there is a possible intracardiac or intrapulmonary shunt. Typical features of a shunt: there's an increase in AA gradient, right, as you can imagine, and it's very difficult to correct with supplemental O2. So these are those patients with bad bacterial pneumonias or ARDS, have horrible gas exchange. This is a good picture and helps to really explain the concept even more. Again, we have the alveolar unit. We're breathing in FiO2, room air at 0.21, 21%. Venous blood is coming here. You're engaging in effective gas exchange, and now you're having good arterial oxygen. When you have a shunt, you can see this is blocked off. You're not ventilating this lung unit. And so venous blood is coming in. I really can't unload carbon dioxide. I really can't take up oxygen. And so the venous blood goes through that lung unit, not being oxygenated, and then it mixes with other components of the blood and goes into your systemic circulation. So you can see how this patient can become hypoxemic. Good. So now you figured out that case, right? 9 o'clock's rolled. You've gotten a win in your belt. You saved a patient's life. You figured out everything. You started the antibiotics. And now 11 comes around, and you were hoping you wouldn't get any more admissions, but it's 11 o'clock in time for your second admission. So you have an 84-year-old female. She's demented, bedbound, hypertension, CAD, GERD, coming again from a nursing home, this time for increased work of breathing. In the ED, borderline hypotension, 101/54, tachycardic to 127, tachypnic to 31, and hypoxemic, 86% on room air. You'll notice I'm saying hypoxemia, not hypoxic, because we don't know if the patient is having tissue hypoxia. Right, so hypoxemic to 86%. She started on vancomycin and admitted to the medicine service for possible pneumonia. Again, this time you have the chest x-ray first. So we see this chest x-ray. Take a 5-10 seconds to take a look at it, and then I'll throw the question at you guys. So how would you interpret the chest radiograph? Good. So many people saying normal chest x-ray, vascular congestion in about 13% of the group. So definitely ultrasound can help us a little bit here, much more sensitive and specific for identifying fluid or an interstitial or intraalveolar filling process going on in the lungs. So why don't we do that? So you decide to grab the ultrasound again. It's the same place you left it in the ED. So you pick it up and you look on the right side here, and this is the left side. So this is the right anterior. This is the left anterior. So I'm going to ask you to describe these ultrasound findings in the interior lung fields. I have a feeling this is going to get to 100%, so I just want to watch and see. So we're saying some people think bilateral B lines, 94% say bilateral A lines. So certainly the correct answer is bilateral A lines is the correct answer, and I'll show you why in a second. So again, it's important to understand the difference between the two. A lines are these vertical lines, these horizontal lines right here, reverberation artifact between the pleura and the probe being reflected in air. Again, you see an A-line predominant pattern on this right side and an A-line predominant pattern here on the left side. Some of you might see every once in a while some vertical lines in the background. Again, that's artifact. If you want to know what those are called, they're called Z lines. You can tell that they're not true B lines because they don't extend from the pleura off your screen, and they are not dominant over the A lines. The majority of the time you see an A line pattern here. All right, so we have bilateral interior A lines in the lungs. So we were trying to figure this out. Why are they hypoxemic? So why don't we take it a little step further, and hopefully some of you had some experience with cardiac echo. And if not, don't worry about it. I can help guide you here as well. So this is the peristernal short axis at the level of the mitral valve. This is your left ventricle. This is your right ventricle. Left, right. This is the apical floor chamber over here, LA, LV, RA, RV. Just want you to pay a little attention to what's going on here. The peristernal short and then the apical floor chamber. So what are the echocardiographic findings that we see here? And again, just throw out an answer. If you don't know, it's not a big deal. This is why we're having the lecture. So 100% get right ventricular dilation, but people forgot A lines and B lines. You guys love echo. Good, we'll close the poll. So right ventricular dilation, definitely that's the answer. So if we go back real quick, you can see right here, the RV much bigger than the left ventricle. Normally it's the other way around. The right ventricle should be less than 2/3 the size of the left ventricle. And you can also look at the septum right here being flattened, telling you that there's some pressure overload on the right side of the heart. Normally the left ventricle has a higher pressure, and the septum bulges into the RV. Over here again, you can see the RV just as big or bigger than the left ventricle. And you see another finding up here at the apex of the right ventricle. Does anyone know what that's called? If they want to text that in the group chat. So you have hyperkinesis, McConnell sign. Good job. Excellent, excellent, Jonas, Catherine, perfect. So what you're seeing here is hyperkinesis of the RV apex, and then hypokinesis and dilation of the RV free wall. And that's basically due to an acute RV pressure overload. So you have this patient who came in, they're treating with antibiotics. What's going to be your next step in the diagnostic workup? Again, this is a free text. What would you want to do next? You guys are there, you're looking at the patient, resident hasn't come down yet, you see this going on. CTA, good. PE rule. CTPA. Excellent. And these are all cases that I had with very similar presentations. So this is why we're going through it. They were admitted with one thing, and you really have to figure out what's going on. You don't want to just anchor on a diagnosis. Good. So I agree with you. You get your CTA, PE, you see RV pressure overload, you see A-line bilaterally. That shouldn't be the case if somebody had a pneumonia. So you get your CTA. Give you a few seconds to look at it. And I think it's more apparent based on the lung and the cardiac findings. What is the most likely etiology to this patient's hypoxemia? Pulmonary embolism, absolutely. Congestive heart failure, you'd see bilateral B lines, right? So that's not the case. Pneumonia, you can see bilateral or unilateral B lines, which you didn't see here. You would definitely start to see some consolidation if you were to look at the axillary region or the Plapp's point in the posterior region. Interstitial lung disease, again, that's an interstitial or intraalveolar filling process. You would tend to see B lines, especially if it was causing this degree of hypoxemia. Remember, you're not going to have a little B line in the right apex and the patient's going to be hypoxemic to the 80s. There's something profound going on with the patient. So this is why ultrasound is really an important component to utilize right here. So why don't we just go back real quick so I can point out the PE. This is the CTA. Again, this is the ascending aorta. Here's the pulmonary artery, the left and right. Here you can see that echogenic material within the distal right and left main pulmonary artery. Just stop working. And you can see the saddle embolus right here. The measurements that you saw were just the measurements of the pulmonary artery. You can see it's dilated, bigger than the aorta, indicative of elevated pulmonary artery pressures. And then obviously port pulmonale and McConnell sign indicative of acute port pulmonale pressure overload. This lady actually went for, we activated PERT. She went for thrombectomy, and this was removed overnight. And obviously the antibiotics didn't play a role in this. She needed emergent CT surgery intervention, and she walked out of the hospital 2 weeks later. So she did quite well. She was a visitor from Europe. She came from England. So actually, no, this one was a nursing home. There was another one who I had came from England, but this one did quite well as well. She went back to the nursing home, I believe. So what is the mechanism of hypoxemia here? So again, VQ comes into play, ventilation to perfusion. So here we have wasted ventilation, something we term dead space ventilation. So I'm recruiting lung, I'm able to ventilate the alveoli, but for some reason the perfusion is not getting to the lung. And as you can imagine, if you have large clots, the blood flow isn't able to get to the lung units to engage in gas exchange. So we call that wasted ventilation. So normal people have normal anatomical dead space anywhere in your nasooral pharynx, down your trachea, down your bronchi until you get to the respiratory bronchioles. That's all dead space. It does not engage in gas exchange. Now, with the clots and the thrombi, some of these alveoli then won't engage in gas exchange because the capillaries are not being filled with blood. Etiologies, big ones being pulmonary embolism. But again, pneumonia, ARDS can certainly lead to dead space ventilation. Pneumonia and ARDS can lead to microthrombi and dysfunctional hypoxic pulmonary vasoconstriction. So there's overlap with this dead space ventilation and shunt. Obstructive lung diseases and emphysema can lead to destruction of capillaries, and therefore you won't have effective gas exchange. So again, these mechanisms don't exist in isolation, but usually there is a predominant mechanism leading to the degree of hypoxemia. To break this down a little bit more, this is our shunt, this is normal, this is dead space. We talked about the shunt already. When we have dead space, I'm ventilating the alveoli, but I have a big clot somewhere here, and so the capillaries are not being filled with blood, and therefore I can't engage in gas exchange. So again, dead space ventilation, very easy to conceptualize when we look at this image. Now it's 2 a.m. and you have your third admission. So 65-year-old male, CAD, hypertension, CHF, active smoker, frequent hospitalizations due to shortness of breath, coming in again with shortness of breath, cough with frothy pink sputum, exertional dyspnea, lower extremity edema. In the ED, they're normotensive, slightly tachycardic, tachypnic, hypoxemic, but afebrile. Placed on non-rebreather with some slight improvement to 92% and started on, again, vancomycin like everyone is for pneumonia, and admitted to the medicine service. I've noticed they throw people on non-rebreather because if they throw them on BiPAP or high flow, they tend calling a critical care consult. But if they throw them on non-rebreather, they feel more comfortable admitting to medicine. I've seen that quite a bit. So again, you guys come down there and you see the patient. And this time you get another anterior view. So here's your right anterior. Here's your left anterior. And hopefully by now we're getting a little more comfortable discerning A lines and B lines. This should start becoming routine for you guys. And I encourage you to be doing this whenever you're seeing a patient, at least exploring some thoracic ultrasound can really help you out. So what are the ultrasound findings obtained in these interior views? Excellent. So very clear B lines, those vertical lines, right, moving with the pleura, dominant over A lines, representing an interstitial or intraalveolar filling process. Remember, keep it broad at first. You don't want to jump to a presumptive diagnosis. So interstitial or intraalveolar filling process. So now you do a little echo. Again, peristernal short. This is the LV, this is the RV. At the level of the papillary, maybe a little mitral coming in here. Here's your apical forechamber, left atrium, left ventricle, right atrium, right ventricle. Just bring it back so you can see this peristernal short again. So what is the main echocardiographic finding here? Excellent. So severe biventricular failure, right? We see a depressed left ventricle, certainly a dilated and hypokinetic right ventricle. We see B lines bilaterally. So then this should be easy based on the ultrasound findings that we have. What is the most likely diagnosis, etiology to this patient's hypoxemia? Absolutely. So pulmonary edema, right? So you basically had 3 cases with very similar presentations of hypoxemia, some tachycardia being treated for the same thing, but profoundly different diagnoses because you're using not only your clinical exam, but ultrasound to help identify and understand what could be going on with the patient. So correct, pulmonary edema is the answer here. And then you get a chest x-ray, you take a look at the chest x-ray, either they didn't get it done or it didn't get interpreted, but I always encourage you to look at your chest x-ray, you see this. And this is a very classic appearance for pulmonary edema. We call this the bat wing pattern in pulmonary edema. Classic image that you'll see. And the mechanism here can be multifactorial. So certainly if you fill the alveoli with fluid, you can lead to some shunt, but you can also lead to diffusion limitation. And this is one of the next mechanisms that I wanted to mention. So movement of oxygen from the alveolus to the pulmonary capillary is impaired. And there's a good picture right over here. So you have all your capillaries surrounding the alveoli, and with decrease in diffusion limitation, or I should say a diffusion limitation, you can have, in this case, pulmonary edema building up in the alveoli, and so impairment in gas exchange here. Other common causes of a diffusion limitation being interstitial lung diseases, right? Whether it's pulmonary fibrosis, IPF, or a cellular infiltration, you have thickening of the basement membrane of the epithelium, and therefore impairment in gas exchange. You can also see this in ARDS. One of the prototypical features of ARDS in the exudative phase is hyaline membrane formation, if you guys remember that concept. So you have thickening of the alveolar epithelium. You can also have then destruction of the endothelium and then fibrosis laying down between the endothelial epithelial barrier. So limitation in gas exchange across that alveoli is another mechanism. So this is the third mechanism that we'll talk about. And then the last two are actually very quick. So 99.9% of the time, living in New York City or anywhere around here, you're going to see shunt, VQ mismatch, and dead space ventilation, and diffusion limitation. The two other ones you need to be familiar with are low atmospheric PO2. So if somebody's climbing up Mount Everest, definitely their oxygen concentration will drop. And that's easy to understand if we know the alveolar gas equation, which is right here. So basically your alveolar O2 is equal to your barometric pressure, which is 760 at sea level, minus 47, which is water vapor pressure, times your FiO2, which is 0.21, so 21% oxygen in room air. As we start to climb up the mountain, our barometric pressure goes from 800 down to 7, 6, 5, 4, 300. Right, so you can see how if I start to drop this from 760 down to 300, my alveolar oxygen is going to be much lower. And therefore, it's going to have a negative effect on my ability to saturate my hemoglobin. So that's a pretty easy concept to understand, right? A decrease in barometric pressure leads to a decrease in alveolar oxygen and a decrease in the gradient of the alveolar to the arterial oxygenation. The next one is hypoventilation. And typically we think of hypoventilation as a cause of hypercapnia, and it is, but it also is a cause of hypoxemia. So when we have hypoventilation, we have an increase in arterial CO2. That makes sense, right? If somebody's not breathing, CO2 starts to build up first. As the arterial CO2 increases, that readily diffuses across the epithelium into the alveolus over here. And as our alveolar CO2 increases, by Dalton's law, if you guys remember, the alveolar oxygen will have to decrease, right? Gases, if one increases, another gas has to decrease. So as my alveolar CO2 increases, my alveolar O2 starts to decrease. And just like if I was climbing up a mountain, if my alveolar oxygen is decreased, less is going to be available to cross the epithelium, endothelium into the red blood cells. And therefore, I'm going to have hypoxemia, in addition to hypercapnia that you can get as well. Additionally, when you have hypercapnia and an elevated PCO2 in the blood, that actually binds to hemoglobin much more readily than oxygen. It has a tighter affinity for hemoglobin. It's based on the Bohr effect. You're offloading oxygen with elevated PCO2, and PCO2 will start to bind to the hemoglobin. So there's a second mechanism why you start to get hypoxemia and then maybe even tissue hypoxia when you have hypoventilation. Common causes of this: CNS depression from drug overdose, certainly if somebody had a stroke. We do see this quite a bit in our obesity hypoventilation syndrome patients. It's also, you might hear some of the older attendings talk about Pickwickian syndrome. That's what it was classically called. Impaired neuronal conduction, so ALS, Lou Gehrig's disease, or Guillain-Barré syndrome, myasthenia gravis, muscular dystrophy. And don't ever forget those elderly patients who are coming in with severe kyphoscoliosis, right? They can have low lung volumes, impaired lung recruitment, and definitely at risk for hypoventilation and hypoxemia and even hypercarbia. So that's the final mechanism of hypoxemia. And then obviously we talked about this, hypercapnic type 2 is another thing hypoventilation can lead to. So let's just summarize this. It's already 2:52. I knew I wouldn't be able to get through everything to get to the oxygen therapy, and that's okay. I don't want to bombard you guys with everything, but hopefully by going through cases, we can start to understand the 5 main mechanisms of hypoxemia and how they relate to each other. And here's a quick outline for you, everything we talked about. So low atmospheric O2, I'm climbing Mount Everest, my alveolar oxygen's low, that makes sense. Hypoventilation, I'm not taking in big breaths, either I had a stroke or you're giving me too much Ativan because I'm acting up, or I have kyphoscoliosis. When I have hypoventilation, my arterial CO2 builds up, it diffuses into my alveoli, then therefore my alveolar oxygen drops and I have less oxygen in my alveoli to diffuse across the epithelial barrier. Dead space ventilation. So I am ventilating a lung unit, but I'm not perfusing that lung unit. And the big one being PE, right? But there's many other causes, but PE is just the concept I want you to take home. It's blocking off the blood vessels, so I'm not able to give perfusion to that ventilated unit. Shunt, I'm perfusing a lung unit, but it's filled with pneumonia or ARDS or blood. So I'm not able to gauge a gas exchange. That's a shunt physiology. And then diffusion limitation. Here we talked about pulmonary edema, which can also lead to shunt, but interstitial lung, lung diseases, anything that impairs that gradient from the alveolus to the capillary can lead to a diffusion limitation. The AA gradient really helps us to differentiate the two. With a low atmospheric O2 and hypoventilation, I'll have a normal AA gradient. With dead space ventilation, shunt, and diffusion limitation, I'll have an increased AA gradient. And we talked about that AA gradient already and how it can vary based on age. So it's important to take the patient's age into consideration and not just have a set number for what is an increased AA gradient. The last thing is shunt, very difficult to correct with oxygen therapy. Just think of your COVID patients, think of your ARDS patients, right? On 100% oxygen, still saturating at that 89 to 90%. So much more difficult to ventilate when you have shunt physiology going on. And of course, that can be physiological or that can be anatomical. So we really have to break it up into those 2 different distinctions. And I think probably, second most important point after understanding these 5 basic mechanisms is knowing that they don't exist in isolation, right? And I really just tried to use a case-based scenario so you could understand the basics of it, but ARDS can be quite complex. And I give an example down here. So you could start off with a pneumonia and you can have a physiological pulmonary shunt. That can progress to ARDS, and then you start to have hyaline membrane formation and decrease in diffusion, right? So diffusion limitation. I can then have microthrombi formation and dysfunctional hypoxic pulmonary vasoconstriction, and that leads to VQ mismatch and dead space ventilation. And then something that's very common in our ARDS patients is they develop acute cor pulmonale. And if I have a PFO, I might start leading to an intracardiac shunt. So many of these patients can have overlap, but usually you'll find an initial mechanism and a predominant mechanism leading to the hypoxemia. But definitely you want to keep all of these into consideration when you're managing these patients. So it's 2:56. I want to respect everyone's time and bathroom breaks. 3 minutes isn't enough. So I do have a section on hypoxemia, hypoxia, and how you want to manage it and the different forms of oxygen therapy you can give and the rationale behind different things that you would utilize. I think it's imperative you guys understand that it is directly linked to this presentation on hypoxemia, but it's too much for one. So I'm going to task the chiefs to find another time where we can maybe finish this and I can go over low flow versus high flow versus non-invasive versus invasive, and obviously the benefits of those and why somebody might choose one over the other. All right, so that's something we have to look forward to. So hopefully this gave you guys a good understanding of the 5 main mechanisms, helped for you to conceptualize it. And then really what I wanted you to do is also start understanding how ultrasound really plays a role and why we really tried to provide you with more ultrasound training, especially thoracic ultrasound training, so you can manage these patients. And just by your answers here, you guys have the capability of starting to incorporate this under supervision, of course, into your daily practice. So with that said, we'll have 3 minutes questions I can answer before I go see some screens that are piling up.
Thank you so much, Dr. Salonia, and we would love to have you back for a part 2 of this for sure.
Excellent. And I also have an ARDS presentation that we can certainly do as well if you guys are interested.
Yeah, that would be great.
And I think I'm giving an ultrasound presentation the next month as well. So
Yeah, Dr. Rothman volunteered you.
yeah, he asked me. I told him I would take care of it.
That would be great. Thank you so much.
You're welcome. Any questions I can answer? All right, it looks like everyone understands hypoxemic respiratory failure.
I guess one quick question then for hypoxemic versus hypoxic with like just being tissue, is lactate what we're looking for evidence of just tissue not getting oxygen, or is there another thing that we should be looking for to differentiate?
Good. So lactate is one of them, but remember there's different forms of lactate, right? There's type A, type B. So certainly you're looking for the appropriate condition. So definitely if lactate's increasing, and this is one of the reasons why in my COVID patients, to give you a good example, if somebody was saturating 88%, 87%, and they didn't have any evidence of a lactate or end organ dysfunction, then I'm okay with it, because hypoxemia is different than hypoxia, right? Certainly you're not going to let somebody sit into the 70s or 60s, because then you're going to be dealing with the detrimental effects of that. But lactate is one of those markers of perfusion. And when you're taking in hypoxemia and hypoxia, you want to also take in that oxygen delivery equation, right? So 1.34 times the hemoglobin times the oxygen saturation plus 0.003 times the PaO2. You don't need to memorize that. I unfortunately have to. But you want to look at the oxygen delivery that's going on to tissues, right? So it's lactate's one of them. Obviously, another marker of perfusion being mental status as well. So not just blood pressure, but blood pressure leading to altered mental status, but also hypoxemia and hypercapnia.